see is that with the seizure material, as well as with the information on the eye disorders, medications are fair game. So one of the things you'll see is that a lot of times treatment for those is meds, and especially for seizures. And so that is one of the things that you're going to have to learn about some of these medications. Now, there are probably over 40 different types of anticonvulsant medications, but I'm going to hit on the ones that you see most often and most frequently used in treatment of patients with seizures. Okay? All right, so let me share my screen with you, and we will start where we left off last time. So we had basically gone over the different types of seizures that you might see with working with patients with a seizure disorder or epilepsy. One of the things that I want you to recognize is that status epilepticus, okay? And it most often is referred to as status, okay, is a seizure that lasts more than 5 minutes, or seizures that occur, multiple seizures that occur over 30 minutes or more, okay? It is a potential complication for all of the types of seizures that I talked about, whether it be complex partial, simple partial, the tonic-clonic, the absence, the myoclonic, or the atonic seizures. But the most common type of seizure that we see status with are those tonic-clonic seizures. And what we worry about with that is the risk for anoxic brain injury. Remember, I told you that especially in those tonic-clonic seizures, the use of the oxygen and glucose increases by about 400% because that's how much the metabolism increases. Well, what you see is that very, very quickly that brain runs out of an oxygen supply. And what you're going to find is that patients will possibly have a stroke-like syndrome from experiencing status that is not treated appropriately and promptly. The most common reasons that you see it are infections, alcohol withdrawal. You may see it with head trauma that's severe, cerebral edema, and metabolic disturbances. You can have status with those alterations in sodium, okay? But the most common cause of status is abruptly stopping anticonvulsant medications. Whether it be because they decide not to take them anymore, or what happens is that they run out of money and can't get their medication prescription refilled. It is one of the most common reasons that we see people in status coming into the hospital, okay? And it is a neurologic emergency and requires immediate treatment. Our priorities for this patient are going to be airway and oxygen. Because remember, one of the things we want to do is to give that brain as much oxygen as we can to make sure that we do not experience that anoxic brain injury. Now, one of the ways that we're going to treat it medication-wise is to use lorazepam or diazepam. Now, what classification of medications are those? They are benzos, exactly right. They're the PAMs. So benzodiazepines are the medications of choice. Now, lorazepam, you may also know by the trade name of Ativan, or diazepam as trade name Valium, okay? One of the things that we do with those medications is that we give them as an IV push as a loading dose until that seizure activity stops. Now, one of the things that you can see is that, unfortunately, you can give enough medication to get the seizure activity to stop, but it also causes respiratory depression. And so you may have to have a respiratory therapist to intubate and support that patient's airway. Now, one of the other things that can happen with status epilepticus is that we can have what we call electrical status, meaning that all external manifestations of the seizure have stopped. They're no longer jerking. They're no longer having that drop attack. But their brain is having that very active pattern on EEG. And so sometimes you can stop the physical portion of status, but still have electrical status. And that also can cause that anoxic injury. And so typically what they would do is support them in the ICU and load them with medications to stop that seizure, okay? It is a neurological emergency. Now, when you're talking about care of patients with seizures, as a nurse, you have two jobs and two priorities. Observe what happened and protect that patient, okay? So observe and protect is going to be your motto. When we're talking about assessment, we're going to want to note the description and the length of the seizure. One of the things I do is as soon as I notice that that patient has a seizure, I either start a stopwatch on my watch or I note the time because I want to know how long that seizure is lasting. After the seizure has ended, I may ask the patient if they had an aura or if their family members noticed something. I want to know if that patient lost consciousness. Are we talking about a simple seizure? Are we talking about generalized seizures? And some of those assessments you may have to get from observers of the seizure, okay? These are some of the other things that we're going to look at. The time, that warning sign or aura. Did they lose consciousness? Did anything unusual happen that could have stimulated the seizure? Did they have a head injury? Did they fall and hit their head? Were there flashing lights? Had they been awake all night? Did that patient cry out at the beginning of that seizure? Remember that hoarse cry of that air going over those vocal cords? Could have occurred. What movements did you notice during the seizure? Did that client look to one side or move their eyes or divert their eyes to one side? It can be very important because it can help the physician indicate which area of the brain may be involved. Did they lose bowel or bladder control? A lot of our patients with tonic-clonic seizures do wet themselves, and that's not unusual. Did they have increased secretions? Because a lot of times what happens is that during this period of time during the seizure, they're not able to swallow. And so those secretions, instead of being swallowed like they normally are, may collect in their mouth or may drain or drool out of their mouth. Again, what time did that seizure activity stop? Because I want to know, remember that 5-minute period is one of those danger signs. That's a KDOD. That long time of seizure indicates status, and that patient is in a dangerous situation and can suffer permanent anoxic brain injury. Now, after the seizure, we're going to look at their neurological status. Are they alert? Probably not for those generalized seizures. Are they oriented? Remember, a lot of these patients will have amnesia. You'll have to tell them that they had a seizure because they won't know. We're going to look for signs of hypoxia and loss of consciousness. Okay. In that post-ictal period, remember, post-ictus means after the seizure, we're going to assess their vital signs. And I would expect heart rate and respiratory rate and blood pressure to be slightly elevated. I want to do a neurological assessment. And I want to maintain safety with those patients. Typically, after these seizures, we turn them in that side-lying recovery position and allow them to sleep. Now, remember that post-ictal period sometimes can last minutes up to several hours, because remember that brain has used a lot of the glucose and oxygen, and those rapidly firing neurons need a recovery period. And so that post-ictal period, you allow them to sleep. Now, that doesn't mean you leave them completely alone. You may check vital signs, especially at the beginning of that post-ictal period, and then check every 30 minutes, every hour, to make sure that they're still safe, that they're not having another seizure. Now, our priority nursing diagnoses for these patients: ineffective airway clearance, because remember, they don't have that ability to swallow during the seizure. Risk for injury, ineffective breathing pattern. Typically during that tonic period, they will have a period of apnea. But once that clonic period starts, you will hear somewhat labored breathing. And that's a good thing because at least I know they're breathing. But during that tonic period, that first initial, they may not breathe for however long that period is, usually 10 to 15 seconds. Anxiety is also a priority nursing diagnosis. Because think about it, if they don't know when they've had a seizure, or they don't know when they may experience a seizure, they are going to be anxious about doing this in public, doing this in front of others, or making sure that they're safe. Now, what are some of our nursing interventions? Well, one of the things that you will see is the tongue can fall back and block the airway. The secretions can pull in their mouth. If it's in that tonic phase, those muscle contractions can prevent inhalation. Can be life-threatening, but typically once they come out of that tonic phase, that clonic phase, they begin to breathe in. So what should we do? We should loosen their clothing around their neck and turn them onto their side. That turning them on their side allows those secretions to drain out. Now, you saw in the video that I showed you that they put oxygen on that patient. As I said, don't try to do nasal cannula. Face mask or a Neuro bucket or just blow by oxygen can be sufficient. In the past, one of the things that they would do with patients with seizures is to put a padded tongue blade above their bed in case they had a seizure. And I'm going to tell you, do not do that. We do not put anything into their mouth. Number one, what's going to happen is that it's going to block your airway. Number two, what's going to happen is that once that tonic phase occurs and you try to put something in their mouth, it's going to break teeth. And they can very easily aspirate those broken teeth, okay? So that Yonker suction, that hard plastic suction, if you use it to get rid of the secretions, it goes only into the cheek, between the cheek and the teeth. It does not go between the teeth. This is a K.D.O.T. Do not force anything into that mouth. One of the things that you will see is that people often think that I'm going to put this tongue blade in there to keep them from biting their tongue. The problem is that the majority of time, most people realize that they've started to have a seizure. Those teeth cannot be pried apart. And if you place something in their mouth, it can break teeth. Now, I will tell you that never ever put your fingers to protect them from biting their tongue, because your fingers will be bitten through, okay? I have seen patients, I can remember one time I was at church as a child, and one of the fellow church members had a seizure, and someone, I don't know if you've ever seen those cross pins, that the metal, okay, they put one of those pins in her mouth to keep her from quote unquote biting her tongue. and it was bent in two. So the force is tremendous. So it is one of the things that you don't want to do.
Miss Hyde.
Yes.
Are you saying like after the tonic phase, is that when that would happen, or during the tonic phase?
During the tonic phase, what you're going to see is that they're going to bite down and clench. Okay, and usually during the clonic phase, what you see is with those clenched jaws, trying to put something in those teeth during that seizure is very likely to break teeth. And trying to put something in there again occludes airway. So we don't want to do that.
Okay, thank you.
Mm-hmm. All right. So let me go back. Other interventions, oxygen. Okay, have that suction equipment available. One of the things that I would tell you guys is this: if I have a patient that has a risk for seizures or has a history of seizures, I will go ahead and set up my room to have that suction equipment already set up. I will set up an oxygen supply. The other thing I will do is pad the side rails of that bed with seizure pads, okay? You don't want to take like bedspreads and wrap around the side rails. Yeah, it's padded, but it's just like with babies. Now we used to use all those bumper pads on baby cribs to keep them from banging their head. Well, what we found is that those bumper pads tend to cause airway obstruction if they got up against them and could not move away. Same thing with our patients with seizure disorder. That's why we use the padded plastic that does not conform to their face. Now, if they have a history of respiratory issues during the seizures, probably cardiac monitoring and pulse ox monitoring are going to be one of the things that you're going to do as well. And then again, never use that tongue blade. You can leave it above the bed if you want to as a sign that this patient has seizures, but it should never come down off that wall. In fact, most hospitals don't even do that anymore. We want to keep that bed in the low position, okay? If that patient has been hospitalized for seizures, we want to have IV access, even if they're not receiving IV fluids. Think about it, guys. If I have a patient that is actively seizing, am I going to be able to start an IV on that person? No, definitely not. So I want that IV access there just in case. And typically, I'll tell you, I do not remove that IV, like the saline lock, until they've signed papers to be discharged and their ride is there. I leave it in and up until that moment, just in case. If that patient has an aura, you want them to lie down either in the bed or on the floor or wherever to prevent injury, because they will fall if they have one of those generalized seizures. If they're in the chair, you may have to move them to the floor or quickly get them back in bed to prevent injury. But if I have to lay them on the floor, a lot of times I'll sit with their head in my lap to prevent that head from banging on that floor. Pillows also would be a good thing, or any kind of padding. Now, when you talk about diagnostic procedures with your patients with epilepsy, probably the most common diagnostic that you're going to see is the EEG, the electroencephalogram. Okay. And you can see that this young lady has got EEG leads placed on her head. Basically, they glue them onto the scalp. They sort of move the hair around, glue them onto the scalp with collodion, which is sort of like clear nail polish, okay? It's hard to get out of hair. Baby shampoo will do it. Baby oil will help. But if you have a patient with an EEG, make sure that you get the pads from the EEG tech to help that patient remove that, because, you know, it's like pouring nail polish on a scalp. Eventually it will come off, but sometimes it can be very irritating, okay? EEG can also be done as a invasive procedure, and we'll talk a little bit more about that in just a few minutes. The other thing that you're going to do is CBC, chemistry panel, because again, we want to rule out other causes of seizures. That lumbar puncture is often done if they suspect that infection or a meningitis or encephalitis may be causing that seizure. CT scans or MRIs are often done because I will tell you guys, the most common cause of seizure in a patient that has previously not had one is brain tumor. It is often the presenting symptom for most patients with brain tumor is seizure. I can remember taking care of a 23-year-old that was surfing at Myrtle Beach, and he was out in the water on a wave and began to have a seizure. And they thought that he had hit his head. He almost drowned. But whenever they did his CT scan to look for head trauma, they found a very large brain tumor. And that was the first sign that he had had with that tumor. Now, one of the other diagnostic things that you're going to see is drug levels. If that patient is on an anticonvulsant, they will draw drug levels to see if those anticonvulsants are in a therapeutic range. The majority of time when these patients experience seizures while they're on an anticonvulsant, it's because that drug is subtherapeutic. The other drug levels that you may see would be like opiates or alcohol, to see if perhaps the seizure was caused by withdrawal from those medications. Benzos are fairly commonly, benzo withdrawal is one of the common reasons that we see seizures in some of these patients. Now, before we start talking about medications, one of the treatments that they often do with, especially with children, is this ketogenic diet. Okay. As I said, it's used with children under the age of 8, typically with seizure disorders. And it is somewhat effective in reducing the severity and number of seizures that these children experience. One of the things that you'll see is that this diet has a very high intake of fat, adequate protein, very, very low carbohydrates. Low carbohydrates. And what happens is that it produces a ketosis in the body that produces an anticonvulsive effect. You can see the diet is about 65% fat, 30% protein, 3% or 5% green leafy vegetables or carbohydrates, but 0% sugars, none whatsoever. And that produces that ketogenic effect that reduces the intensity and the number of seizures in these children. Now, adults could use it as well. And in fact, they have just produced a new set of guidelines for the use of ketogenic diet in adults. But why do you think that this is probably more effective in children under the age of 8? Any ideas?
Because of the low sugar content in the diet? I don't know.
Okay, think about this. Who prepares meals?
The parents?
Yeah. And so the parents can control what that child is eating, correct?
Correct.
Okay. Once they get about age 8 or really age 5 or 6, when they start going to school, parents really cannot control what they're eating 24 hours a day.
Okay, yeah, I understand.
Okay. One of the things that I will tell you is that any sugar intake, like one piece of candy at Halloween, basically will throw this diet off for 2 weeks. It decreases the ketosis that much. So a cookie or any carbs that are more than what you see, okay? Typically with the carbs here, we're talking more green leafy vegetables, fibrous vegetables. No potatoes, no carrots, no starchy vegetables, because typically those turn to sugars whenever you intake into the body, and it throws off that ketosis. Okay. Now, does it work? Yes. And in fact, a lot of children that have high numbers of seizures, it has been very effective with those folks. But it's very, very difficult to maintain this diet for long, long periods of time. And in fact, the research that the guidelines for adults basically say the majority of adults go off of it in 3 to 4 months because of the strictness.
Yeah, sorry. Apparently when they go off of it, they gain almost all the weight that they lost when they were.
Well, yeah, but we're not doing it for weight loss.
Okay.
Okay. What we're doing it is to induce that ketosis.
Got it.
Okay. And basically it's the ketosis that causes the anticonvulsant effect. And the weight loss is a sort of a benefit or side effect, okay? But that's not what we're doing it for. But yeah, there are a lot of people that use keto diets for weight loss, and they're very effective. But think about what some of the side effects of this diet would be. I mean, constipation is a major issue because if you're only taking in about 5% fiber, very low fiber diet. The other thing, of course, if 65% fat, hyperlipidemia can be a problem. And we also see kidney stones or renal calculi with these patients quite frequently. And those are the common complications that you see. So with patients on this diet, usually, how do we prevent constipation? Well, we increase fiber, we increase water. Well, we can't increase fiber. So these children may have to have stool softeners and things like Miralax in order to prevent that severe constipation that occurs. The hyperlipidemia, maybe have to go on statins. And with that kidney stones, we're often watching for problems with blockage from urination or pain or colic, renal colic, so to speak. So those are things that you really worry about with these patients on ketogenic diets. Okay, so let's look at some of these medications. One of the things that you'll need to recognize is that the choice of the medication is dependent on the seizure type and characteristics. So that treatment for these patients is very individualized, meaning that someone with absence seizures are probably going to be on one type of medications. People with tonic-clonic seizures will be on other types. People with complex partial seizures will be on a third type. And what may work for one patient, even with the same type of seizure, may not work for another. So it's very individualized. That's why it's very important whenever these patients develop the seizure disorders that they are referred to a neurologist that specializes in seizure treatment. One of the things that you'll see are there are many common side effects and many precautions that you have to take with these anticonvulsant medications. How do they work? Well, what they do is suppress neuronal discharges. And they prevent, or we hope they prevent, that abnormal focus or that point where the seizure starts from either forming or spreading. A lot of them act by controlling the movement of electrolytes like sodium and chloride and calcium across neuronal membranes. Or they affect the neurotransmitter balance by increasing GABA. And remember, GABA is one of those neurotransmitters that calm things down. Okay? It's a calming neurotransmitter, whereas acetylcholine or norepinephrine are active neurotransmitters. A lot of times that they increase GABA by increasing the amount that's synthesized. They block its reuptake, and they also activate GABA receptors. So many, many ways that it can work. However, one of the things you need to remember is that they're all metabolized in the liver, excreted by the kidneys. So if we have patients that have liver dysfunction or renal insufficiency, they have to be used with precaution. One of the things you also need to recognize is that the body develops tolerance to a lot of these medications. And so often the dose has to be increased for it to be effective. So it's a constant reset of the amount that you get to prevent seizures. As I said, has to be individualized. What works for one person may not work for another. And a very, very important teaching point is that they need to continue these medications. We should not stop them abruptly, especially if they've been on them for a while. Remember, that's the most common reason why we see status epilepticus in this population. Now, they've only been on this med 3 or 4 days, then that's not a big deal. But more than 7 to 10 days, a lot of them have to be tapered for withdrawal, okay? For all of our anticonvulsants, regardless of the class, we want to monitor the level of consciousness because they can cause drowsiness. That usually improves in a few weeks, days or weeks. It can cause slurred speech, confusion, and incoordination at the beginning. And so they're told to avoid any hazardous tasks or to use caution because of the risk for falls or injury. Because these meds are typically metabolized in the liver and excreted by the kidney, we want to check the liver and kidney function frequently. Not only do we want to look at like AST and ALT for the liver, BUN and creatinine for the kidney, but we want to check drug levels for specific medications to make sure that they're in therapeutic range. As a rule, the majority of them cause photosensitivity. So these patients should wear sunscreen with a 30 SPF or greater. They should always check with a pharmacist before taking any prescribed or over-the-counter medication. Anticonvulsants can increase the risk for depression, suicidal ideation, and psychosis. And in fact, they, as a class, have a black box warning on them for suicidal ideation, especially in that 19 to 26-year-old age group. Okay, so that is one of the things that we want to assess. They can cause decreased concentration, And so until that patient becomes a little used to that medication, their schoolwork may suffer. We have to use caution with herbals like ginkgo or St. John wort. Okay, grapefruit juice can alter their levels because a lot of them use that same pathway, that CYP protein that grapefruit juice alters. Some of them can cause either severe weight gain or anorexia. People are more likely to take them if they cause the anorexia than the weight gain, especially women. Some can cause nausea and acne-like skin eruptions. This is one of the cautions that you need to let patients know about. As a general rule, the neurologists that I work with always prescribed brand name medications, okay? And the reason for that was that if you switch from generic to generic to generic, because this is what the pharmacy has this 3 months because it's cheaper, sometimes you have to figure out what level you need to give, because even though generic medications are supposed to be bioequivalent, I can tell you that with anticonvulsants, a lot of them are not. And it may take adjustments to get the same effect. I've seen patients that have switched from a generic that they've taken for 3 or 4 months, and then their pharmacy switched to a different company because it was cheaper. Experienced seizures come in and they would be subtherapeutic. So you need to caution them about that. Like I said, a lot of my neurologists that I work with would only do brand name versus generic, unless the pharmacy could guarantee them that the generic would stay the same. Now, I had a question. Does taking an anticonvulsant for a condition other than seizures, abruptly withdrawing it, can it cause them to have seizures or go into status? And the answer to that is yes. Okay. A lot of times patients may take these for migraine. A lot of patients will take anticonvulsants for neuropathies, okay, like a peripheral neuropathy, like our patients with diabetes, or they may take it for like tic douloureux, which is like facial pain. Abruptly stopping those meds after they've been on them a while can induce seizures in a patient that does not have a seizure disorder. So that is also a caution for those patients as well. Oh, what happened? Oh. All right. Now, I don't know how many of you have ever looked up to see what Stevens-Johnson syndrome is, but a lot of your anticonvulsants can cause Stevens-Johnson syndrome. And I know you've seen it in your med book, and it's always underlined in red because it's an extreme adverse reaction. This is what Stevens-Johnson syndrome is. the epidermis of this skin will separate from the dermis. It starts off as this rash and blister, and the skin will slough off. Now, it can be external and it can be internal in the mucosa. So patients that experience this, it is a somewhat life-threatening response, adverse effect of anticonvulsant therapy. Unfortunately, with this, yes, I'm abruptly stopping that anticonvulsant because it's developed this syndrome. Eventually, when this skin sloughs off, I have to treat this patient just like they've experienced a burn and do dressings and treatment and high level of infection control to prevent this wound from becoming infected. Okay, so that are some of the things that you need to think about as a general rule for anticonvulsants. Now, one of the new things that has come out in, of course, you know, if you look at the popular press or the newspapers or the every ad on in the world, marijuana treats everything, okay, or CBD or cannabidiol. Okay, cannabidiol is a non-psychoactive ingredient in marijuana. And it is, the indication for it is for patients that have Lennox-Gastaut or Dravet syndrome. Okay, these are patients or people that will have possibly as many as 200 seizures a day. Okay. In the state of North Carolina, cannabidiol is only legal for treatment of those two syndromes. And it has to be prescribed by a physician at one of the major medical centers, CMC Maine, Wake Forest Baptist Hospital, Duke, UNC Chapel Hill, or the hospital in Greenville, North Carolina, okay? Those are the only patients it is legal to take in the state of North Carolina. They've done a study that showed that with these patients with these two particular syndromes, there was a 50% reduction in seizures in about 39% of the patients. Now, it does have a lot of drug interactions, and they did find adverse effects in about 47% of the patients. Some patients even increased the amount of seizures that they had or developed a new type. The most common thing that you would see was that new seizures. Fatigue in about 14%. And they did have two patients. They had to require intubation to maintain airway, and they did have one death. But cannabidiol is one of the medications that you may see, particularly for Lennox-Gastaut or Dravet syndrome, okay? It is not approved for any other type of seizure, regardless of which state, okay? But I will tell you, you will see a lot of patients use either CBD or some of the compounded marijuana type medications to help control their seizures. But the only evidence-based practice study that I have seen are in these two syndromes. Okay, so I have got that it's 1:55. Before we start going over some of the other MADs, let's take a 10-minute break and be back at 2:05, okay?
Okay.
Let's see. All right, so let us go back to screen share. And we will talk about a classification of meds called barbiturates, okay? Now, we don't use them as much as we used to because they do have a potential for dependence and abuse. They also cause respiratory depression. However, they're very inexpensive and they're very long acting. These are meds that are on that $4 list at the Walmart or a CVS. And so sometimes they're used for patients with lower socioeconomic levels because they can afford them. Some of the newer anticonvulsants are extremely expensive and are often out, they're priced out of being able to get those medications. Barbiturates are usually used to treat tonic-clonic seizures. They can also be used to treat partial seizures. Now, one of the things that I will tell you guys is that I've given you information like that, but do you have to pick out which of these medications is used to treat tonic-clonic seizures and then give you a list of anticonvulsants? No, because you are not going to be prescribing, okay? But I want you to know that they can be used to treat those types of seizures. Now, with barbiturates, we can give these with status epilepticus, and they're often given to children with febrile seizures. And we may also use them to treat eclampsia. Okay, remember with our pregnant women that have those hypertensive problems in pregnancy that can develop seizure disorder, they can be given barbiturates to stop that seizure. Now, barbiturates can be given PO, IV, or IM, okay? Typically, what you're going to see is if they're taking them on a routine basis, they're going to be given PO. If we are using it to stop status, if we've got an IV site, you're going to see it giving IE. If we don't have an IV site, it can be given IM, but it takes much, much longer to stop that seizure for that medication to be absorbed. Now, some precautions about barbiturates: they can cause agranulocytosis, which means that we may have a patient that can have alterations in their complete blood count. They can cause respiratory depression, bradycardia, CNS depression. They make people sleepy as all get out. And it can cause coma if the levels become too high. You never just stop it. It has to be tapered if they've been on it for more than a couple of weeks, okay? Some of the examples are phenobarbital, ambibarbital. The one that's not the barbital is primidone, okay? It's a barbiturate, and mycilin is a medication that you will see that's given a lot of times to your patients that have those simple partial seizures. It can interact with many other medications and cause increased metabolism of the other meds. You need to watch levels closely if it's being given with Depakote, because it can raise those phenobarb levels significantly. Now, when you're talking about therapeutic range, you're talking about a normal level of 10 to 40. But what can happen is that because this medication causes tolerance, you may have to go higher than that to have therapeutic effect. So what does that mean? If my normal level of a patient that's on phenobarbital is between 10 and 40, if they're between those two numbers, they should not experience seizures. However, some patients may have to be closer to the 40 than to the 10 for seizure activity to stop. One of the things you have to be very careful about is that if given with phenobarb, it can cause decreased digoxin levels. Okay, so many meds that it interacts with. And that's worth a call to the pharmacist if this patient is placed on phenobarbital. Have to give it with caution with warfarin. It can either increase or decrease clotting times. Kadioti. Phenobarbital has higher than normal risk of birth defects if taken during pregnancy. So typically we need to educate women of childbearing age that are on this medication to have reliable birth control. Now, if they plan to become pregnant, typically you will see that most neurologists will try to switch them off of this medication to another medicine for seizure control because of that risk of birth defects. Now, our benzodiazepines, like our diazepam or the clonazepam or the lorazepam, and then there's the odd one out, clorazepate or transine. Our benzos also enhance the action of GABA. The primary indication for this medication is status epilepticus. If it's given IV, the onset of this medicine is fast, as little as 60 seconds. However, it can cause hypotension, tachycardia, edema, cardiovascular collapse, drowsiness, fatigue, ataxia, dizziness, vertigo, urinary retention, and laryngospasm. The one I'm worried about most often is that laryngospasm and that hypotension. Okay, it also causes respiratory depression. Now, when I am giving either lorazepam or diazepam, because of this risk for cardiovascular collapse or tachycardia, I would prefer that my patient be on cardiac monitoring. The other thing is, depending on how much this medicine takes for me to stop that seizure, I may want to have my respiratory therapist standing by so that they can intubate my patient and protect that airway if they stop breathing. Now, if they're taken long term, there is the risk for substance abuse or dependence. But typically, we do not give these medications on a long-term basis for seizure control. We also give these medicines sometimes prior to procedures to relax that patient because it can cause sedation. Benzos like lorazepam or diazepam can be given PO, IV, or IM. Typically, we use IV if we are giving this medicine to stop that seizure. And the majority of time, you're giving like 2 milligrams over several minutes, over 2 to 3 minutes, and seeing what effect it may have. And then you may repeat it. I will tell you the majority of patients will have respiratory depression after you've administered at least 6 milligrams. So that is something to watch out for. Now, if they have alcohol intoxication, you will have added effect for sedation. Typically, it's contraindicated in patients with narrow angle glaucoma. It also can cause birth defects. It's secreted in breast milk and can cause CNS depression in infants. This is also a KDOD, guys. With benzodiazepines, our antidote is flunarizumab or Ramazicon, which is the trade name. It's that benzoreceptor agonist that reverses CNS depression from either diazepam or lorazepam, okay? So if they overdose on benzos, flunarizumab is going to be your antidote. If you give Narcan for a benzo, it will not have any effect. So typically, if you've got someone that ODs in the emergency department, they start with Narcan. And if there's no response, then they will give the flunarizumab. It can worsen Parkinson's syndromes. It will cause phenytoin levels to elevate. And with MAOIs, it can cause hypertensive crisis, okay? Our hydantins, phenytoin or fosphenytoin, are the two in this class that we use most often. Phenytoin, we would give PO. It can also be given IV, but it's very dangerous to give it IV. Typically, what we do is fosphenytoin, which is a precursor of phenytoin. To administer phenytoin IV, you have to do it as a direct IV push, okay? And a lot of times, whenever I am using this to treat status epilepticus, I am administering as much as a gram by direct IV push, which is going to take me about 20 minutes. Fosphenytoin is a medication that you can administer by piggyback. Put it on a pump and don't worry about it. It does not have as bad a side effect profile. And you can be doing other things instead of sitting at that patient's bedside. Yeah, you're keeping an eye on them, but you're not having to do this as a direct IV push. So If you see phenytoin, think PO. If you see fosphenytoin, think IV. What does it do? Well, it slows influx of sodium ions, and therefore it will slow the spread of those abnormal discharges. There's less CNS depression and potential for abuse than with your phenobarbitals. Now, it is an older medication, but it is still on that $4 list for Walmart, CVS, Walgreens, whatever. And a lot of times, if patients are unable to afford those newer medications, you will see them use Dilantin because it's much cheaper and much more affordable for patients that don't have insurance coverage. It can be used for all types of seizures except for absence seizures. We use it IV in status. Now, when you talk about cardiac, it can be used for ventricular tachycardia, especially if it's been induced by digitoxin toxicity. Now, some of its off-label uses are headache. We see a lot of patients use it for diabetic neuropathy or neuropathic pain, because one of the things that you will see that a lot of anticonvulsants are used for pain syndromes because it also stops that spread of that pain from one area to the next. So a lot of patients may be using this for pain instead of for seizure control. But again, it is one that you have to taper these patients off. You can't just abruptly stop them if they've been on it for a while. This is one of the big KDOTs. It can cause what we call gingival hyperplasia, which means the gums grow over the teeth. The way that we prevent that is brushing and flossing. A lot of times patients on Dilantin or phenytoin need vitamin D and calcium supplementation because it can demineralize bones and cause an osteoporosis. They need frequent lab checks to check their levels to see if they're therapeutic. Therapeutic level here is 10 to 20. Now, above 20, you're talking about serious side effects to the point of lethargy and coma. Above 40, okay? So we want them to be in that very narrow range. It can't be given quickly IV push. Phenytoin can be given at no more than 50 milligrams per minute, or it can cause cardiovascular collapse. And here there's some of the other things that you can see. Lethargy, headache, drowsiness, confusion, coma, seizures, if it's given too quickly, bradycardia, VFib, hypertension, weight loss, liver necrosis, agranulocytosis, thrombocytopenia, aplastic anemia, and rash. So that IV push, phenytoin, within the past 10 or 15 years, they've gone to fosphenytoin because of the safety mechanism. It's much easier to hang that as a piggyback and get it at the correct rate. Now, couple of things. These shows you what the gingival hyperplasia look like. You can see how puffy and overgrown these gums look. Okay. And that is a direct side effect of phenytoin. As I said, brushing, flossing helps to prevent that. But I have seen some patients that have had severe enough gingival hyperplasia that they had to have part of their gums removed in order for their teeth to show. The other thing that's extremely dangerous about phenytoin IV is it causes extravasation of the skin. pH is about 4.5. It's an acid. And so it does cause skin breakdown to the point where you may have to have skin grafts in order to close that wound. So you want to make sure that you've got a very, very good IV if you're giving it IV push. Typically, I prefer an antecubital site because it dilutes the medication much more because of the very much larger vein. Multiple drug interactions. Typically, it's not given with warfarin. Alcohol use and barbiturate use can increase its levels. It's not a good drug of choice for patients that are diabetic because it can cause decreased blood sugar levels and poor blood sugar control. Again, don't stop this med suddenly because it can cause status. All right, what happened to my chat? All right, let me see what that question was. Does the extravasation happen because of infiltration? Yes, it does. Okay, anytime you have that IV that infiltrates or leaks and that medication gets in that skin, it will cause that breakdown. Okay, all right. Any questions about those anticonvulsants so far?
Yeah, I have one question.
Sure.
Back to the barbiturates, the level you were saying from 10 to 40.
Uh-huh.
Are we watching the patient like closer to 40 for seizures? Can you explain that to me one more time?
No. Basically, what you worry about seizures would be outside of that range. If it was below 10, okay? Usually above 40, they're not going to be having seizures. They're just not going to breathe. They're going to be comatose, so to speak. Okay, because remember, it is a sedative medication. The more you give them, the higher the level might be, the more likely they are to be knocked out, so to speak. Okay, now what I was saying with that is that even though 10 to 40 is therapeutic, some people may seize if their level is at 11. What I'm looking for more is a midline. So say around 25 or so. If my patient is having seizures at 11 or 12 of their level, then what you see is the physician will probably increase their medication milligrams that they're taking to bump it up closer to that mid or upper range. Okay. So even though they're in therapeutic range, some patients still may have seizures in that lower level. You don't have seizures above the 40. You typically are having decreased level of consciousness or coma because of the sedative effects. Okay. Do we need to know the interactions for each medication and for the additional treatments besides seizures? I wouldn't worry so much about the interactions with other medications, but I'm going to talk about some of the other treatments when we talk about peripheral neuropathy. So I would know that, yeah, they're used to treat some of those other things. Okay. All right, let's go back to share again. Now, the iamminostilbines, these are your carbamazine or oxcarbamazine, the Tegretol or the triliptal, okay? Anticonvulsants. Tegretol is also used as an anti-seizure. It can be also used as anti-pain as well. It's inexpensive, fairly low side effect profile compared to others. A lot of times is used for tonic-clonic and partial seizures. It can be given with other epileptic meds. And that's one of the things that you'll see, guys, is that some patients may be on multiple meds for seizure control. It's extremely rare that you will have a patient only on one drug. Typically, what they will do is start them on one drug and increase their level until it gets therapeutic. But they don't want to go outside of that range and become toxic on that medication. If they're still having seizures, they will add another drug, okay? A lot of times what you will see is that monotherapy or treatment with one drug often is not effective for patients with seizures from epilepsy, and they will be on more than one drug, maybe even up to 4 different drugs because they have different effects. These medications slow those sodium channels, and they don't know how it works, but it does, okay? They also will have the antidysrhythmic, antidepressant. They can act as muscle relaxants, and they sort of a calming or sedative effect. You may see this one used to treat mania, diabetic neuropathy, trigeminal neuralgia. Okay, that's that face pain of that 7th cranial nerve. Hiccups. And a lot of times we use this one for our patients that have dementia or agitation. Okay. We do need to check frequent blood levels. Therapeutic level is 4 to 12. One big thing to think about with teaching with these patients is that this class of meds, like the Tegretols, decrease effectiveness of birth control pills. And so if they're on a birth control pill for their reproductive control, they may have to use an alternate method in addition to those birth control pills, like condoms, because they can become pregnant on these meds. Side effects, CNS depression, confusion, blurred vision. You see Stevens-Johnson syndrome with this. Impotence in males and urinary retention. We typically do not use this med in patients with lupus, with hypertension, or coronary artery disease. Again, don't give them with MAOIs because they can cause hypertensive crisis. Triliptal, the oxycarbazine, partial seizures. Again, decrease effectiveness of birth control. Watch out for Steven Johnson's. And it also acts as a mood stabilizer. Okay, so you may see this one with your patients with bipolar disorder, in addition to your patients with seizures. Now, some of the miscellaneous medications, gabapentin or valproic acid, these are anticonvulsants, but you probably recognize gabapentin from taking care of your patients with a peripheral neuropathy, because that is one of the things that we use it for. Now, the difference between it as a anti-seizure medication and the medication for peripheral neuropathy is dose, okay? Typically, gabapentin, if it's used for peripheral neuropathy, is 100 milligrams 3 times a day. If it's used for seizures, then we are seeing 300 milligrams 3 times a day. It's almost triple, okay? Gabapentin can also be used for hot flashes, spasticity. We use it a lot with our patients with multiple sclerosis. Now, one of the things you need to remember about gabapentin is it's not metabolized. It's excreted unchanged by the kidneys. So we can use this med in patients with hepatic or liver impairment, but we cannot use it in patients with renal impairment or kidney problems, okay? What are some of the side effects? Well, GI symptoms, drowsiness, fatigue, dizziness. A lot of times you see nausea and diarrhea. It can cause hostility or emotional liability in children. We don't give it within 2 hours of antacids because it renders it ineffective. Now, valproate or divaloproate sodium, we use this to treat absence seizures and complex partial seizures. You've heard about it before because of mania. We can also use it for behavioral disturbances from dementia instead of using antipsychotics. Hiccups. Therapeutic level is 50 to 100. Again, this is one that can cause birth defects. And so we need to make sure we educate women of childbearing age to have very reliable birth control methods. When you look at this, basically, this is probably the most important one. We don't use it in children under the age of 2 because it can cause fatal hepatotoxicity. It also can cause hyperammonic encephalopathy. Their ammonia level elevates. We can use Narcan on this medication because it has an opioid-like effect. You can also hemodialyze them to lower their blood serum levels. Now, with pregnancy, basically what you will see is that people that have an underlying seizure disorder, their seizure episodes increase about 25%. we have to remember that a lot of these meds have tetragenic properties. Phenytoin and carbamazine have basically been linked to fetal anomalies like cardiac defects, cleft lip, cleft palate. Valproic acid has major congenital malformation in infants in about 4 to 8% of pregnant women that take the drug. Anticonvulsant medications act like inhibitors of vitamin K. And so these women that are taking these medicines are prone to hemorrhage after birth. They are also, their infants are prone to hemorrhage. So one of the things that, in addition to the vitamin K injection that we give immediately after birth to all infants, we want to do oral vitamin K supplementation for the last week or 10 days of the pregnancy. And that helps protect mom as well as baby. With all anticonvulsants, you need to increase folic acid supplementation. Yeah, remember we use folic acid for all women to prevent neural tube defects. With patients that are taking anticonvulsant therapy, the dose needs to be increased because it causes loss of folate. All right, let me stop the share because valproic acid, yes, is the same as divalproic sodium. Yeah, it's the same. All right, so any questions on anticonvulsants? All right.
Then in the chat. For the therapeutic level 4 to 12, is that for Tegretol?
Yes.
Okay.
Okay. So sharing screen again. Now, what if these medications don't control seizures? And there are a lot of patients that they don't, even after 4 different medications have been added. Sometimes they will do vagal nerve stimulators where they will implant a device that stimulates the vagus nerve to try to decrease the incidence of seizures. It's more of a palliative measure for patients that have those severe seizure disorders. But there are some conventional surgical procedures that work very well in decreasing and maybe even eliminating seizures in some populations. Now, that partial corpus callosomotomy, the corpus callosum is that connection between the right side of the brain and the left side of the brain. And if I sever that seizure cannot become generalized. And so what you see is that they may do that to keep that seizure from enveloping the entire brain. The other thing that they may do is what we call a partial lobectomy. Okay. No, they don't take out the entire frontal lobe or the temporal lobe or the parietal lobe, but a small piece of it that the seizure starts in, so that if you remove that seizure focus, then hopefully that patient will not have seizures any longer. Okay. So let me see what the question was in the chat. I don't know why it doesn't show up. Hang on, stop. Can you explain what the implant does again? I didn't catch it fast enough to write it down. The vagal nerve stimulator, basically it's sort of like an overdrive pacer, okay? It senses that seizure beginning to start, and so it will stimulate that area and then just bring it down to try to keep that seizure from focusing. It's more palliative. It's not something that they put in for everyone. It's more for those folks that have a couple hundred seizures a day. Okay. When you're talking about the partial lobectomies, the majority of time, what you will see these done for is those patients like John that have those temporal lobe seizures or those complex partial seizures. Okay. And what they do is they figure out where that seizure starts, and then they remove that portion of the brain. And hopefully their number of seizures decrease or maybe even go away. So as part of their pre-op workup, they do neuroimaging, CTs or MRIs, to make sure that there's no other neurological cause for those seizures. They will do the scalp EEG. And what they do is often bring them in for seizure monitoring, okay? Where I put the EEG leads on this patient, I am videotaping them for 24, 48, 72 hours, however long it takes for them to have a seizure. They're typically brought into the hospital because what we do is take them off their seizure meds, because what we want them to do is to have seizures while they've got this EEG in place and while the video is running. If you've ever been up on the Neuro unit at Northeast, they have seizure monitoring room. That room, the entire room is on camera. The only place that's not on camera is the bathroom. And so what happens is that if a patient goes into the bathroom, a nurse or a non-family member has to be with them in case they do have a seizure. They also do what we call neuropsychological testing. And this is not, the test that you would do for someone that comes into like a mental health unit. Neuropsychological testing is more cognition and the ability to think and process. It's not about mental health. It's how learning is done and how reading is done. The other thing that they will do is what we call a WADA, W-A-D-A test, where they give them intercarotid amibarbital and basically paralyze half of the brain. Because one of the things they don't want to do is to cause more harm than good when they take out that part of the brain. One of the things that you will see is that 90% of us, even those of us that are left-handed, are dominant on the left side for speech. So what they do is they paralyze that right side of the brain and have patients to read or to talk. And if they can still talk, then that means they're left dominant. Whenever they paralyze the left side, they're not able to speak. And so if they have their seizure focus near that speech area, they may not be able to do the surgery because they would not be able to talk afterwards. Now, the other thing that they will do is what we call invasive intracranial EEG. Okay, remember the EEG we did before was external. It's on the scalp. This is actually placing electrodes into brain tissue. Because once they have identified the general area on that external EEG, they want to do that invasive intracranial EEG and see at what depth and what specific location that seizure is originating from. And then that's the area that they're going to remove. Fairly extensive workup for these patients, because one of the things we don't want to do is to cause them more harm than good. After they've had the partial lobectomy, a lot of these patients, probably about 60 to 75% of these patients, will be seizure-free with no medications after about 1 year. So they may have gone from 4 medications and still having seizures to, after the surgery, 1 or 2 medications and no seizures. Now, what are some of the things that we have to talk to our patients about with their diagnosis of a seizure disorder? Probably the biggest thing is going to be things that are going to affect their safety. Driving is a biggie. One of the things that you will see is that in the state of North Carolina, you have to be seizure-free for at least 6 months before you're allowed to drive. Now, who polices that? Well, it's not a reportable thing to the DMV. Okay? However, if they have a seizure or a seizure disorder, one of the things that will happen when we're discharging these patients, do not drive until you're seizure-free for 6 months is part of the discharge instructions. And if they are driving and the insurance company finds out about that and they have a seizure and cause an accident, their insurance company does not have to cover any of the payment for that accident. Now, if they have a commercial driver's license, usually it's seizure-free for a year. Typically, we don't like these patients to be on ladders or work in construction where they're at heights. We don't want them to do power tools or other equipment, especially until we see what effects those medications are going to have. Baths are probably not a good idea, or swimming alone definitely is not a good idea, because if they seize and slip under the water, they can drown very easily if they're not monitored. Typically, we recommend showers to our patients with seizure disorders. We need to teach them about the importance of adhering to their medication regimen. And we need to talk to them about making sure that their blood levels are monitored. Typically, you will see that when we're starting on those medications, those will need to be fairly often, or any changes, they need to do a blood level. Now, there are some new things that have come out that assist with seizure monitoring. This Embrace smartwatch actually will detect seizures and will alert a caregiver that that patient is having a seizure. Again, they need to follow up with their neurologist or their epileptologist, someone that specializes in epilepsy. These are not medications that you want your family practice person taking care of. If they're discontinuing anticonvulsant therapy, typically what you're going to see is that it will be tapered, okay, if they've been on that medicine for a while. And then started on others. You can start while you're tapering the one, and that's probably the better choice of doing it, because as the therapeutic level of that one is going down, the therapeutic level of the other med is building up, and that patient will be less likely to have seizures. So, what kind of questions do you have about seizures? Anything? As a nurse, what we're going to be more concerned about, as I said, is observing what that patient is doing and protecting them from harm. One of our other major roles is teaching for those lifestyle changes, those medications, what to look out for, what side effects, and how often they need to have those levels monitored. Okay. All right, let's take another break, and then we will start on the sensory perception handout. What about the side effects and meds and teaching? Side effects and meds, the teaching for those medications that you would need to do with the patient, what they need to know is considered fair game for this test. What about knowing the difference in the different types of seizures? Yes, that is also fair game, because I think you need to know the difference between the types of seizures. What would you see with an absence seizure? What would you see with the atonic seizures? You know, because what you see and how you would protect that patient is going to be a little different than it would be for someone that's experiencing tonic-clonic seizures. Okay. So yes, I would know the difference between the different types of seizures, and specifically the side effects of those medications that I've talked about that can be problematic for those patients. You definitely need to know about. Okay.
Miss Hyde.
Yes.
My question would be like, okay, so I'll use barbiturates, for example. I need to know that do I need to know what types of seizures it treats?
No.
Or just that it treats seizures?
It treats seizures. Mm-hmm.
Okay. And then for testing purposes for this exam, do I need to know it treats eclampsia, or is that just a good to know?
It's a good to know.
Okay. Thank you.
Mm-hmm. Most of the time, Becca, what you will see is that phenobarbital, like I said, it's a fairly inexpensive drug. And And so patients will be on it because they can't afford some of the newer, more effective medications. If they can't afford the med, why are we prescribing it to them whenever they're not going to take it because it's too expensive? Yeah, phenobarbital is an older drug. It's cheap. It has more side effects. But if they're careful with monitoring for those side effects, it may help prevent seizures and therefore a better quality of life for that patient.
But if they're not going to monitor closely for those side effects, you'd want to give them a benzodiazepine.
Well, typically we give benzos only for status. Okay. They're not medications that you're going to give for day-to-day seizure control.
Okay.
Because of the dependence and the potential for abuse and the other side effects that you get with that.
Okay.
But we will use them to stop a seizure while they're in the hospital or to stop status. But it's not something that they're going to be prescribed on a long-term basis for daily use.
Okay. Okay, thank you.
All right. Any other questions about seizures? Okay, let's go ahead and move on to the sensory perception stuff. Oh, wait a minute, wrong one. There we go. What you're going to see here are some of the eye and ear disorders. Okay, so what we're going to talk about are what are some of the syndromes that will happen that you may see with some of your patients. Now, as a general rule, there's a difference between impaired vision and blindness or low vision, okay? And these are definitions that are basically developed by the federal government. And what we see as impaired vision is a visual acuity of 20/40 or worse when wearing corrective lenses. Okay, meaning that even with glasses, their vision can't be any better than 20/40. And by 20/40, what I mean by that is that the 40 is a person with perfect vision can see at 40 feet what this person has to be 20 feet closer to. Okay. So what you find is that in visual impairment, anyone with 20/40 vision or worse when wearing corrective lenses. And guys, I will tell you, in the state of North Carolina, your vision has to be at least 20/40 for you to be able to drive. Okay. When you're talking about legal blindness, that's vision that's 20/200 or worse in the better eye, or that visual field of 20 degrees or less in diameter. That visual field of 20 degrees or less basically would be about like tunnel vision. Okay, you can only see directly in what is in front of you. You don't have peripheral vision. That's legally blind. Now, when you're talking about Medicare, they basically consider low vision as being worse than 20/60 visual acuity in the better seeing eye. It can be 20/200 or legally blind in the right eye, but as long as they have 20/60 In the left eye, it's considered low vision. Well, why are these definitions important? Well, in 1991, Medicare started coverage for low vision. Okay. Though those visual requirements for driving vary, most states, the visual fields is 120 degrees horizontally. And remember that legally blind was only 20. So they have to have some peripheral vision in order to be able to drive. Vision loss is one of the most emotionally devastating physical problems that you can experience. And what you will see is that that impact extends beyond functional problems and involves a lot of psychosocial issues as well. Approximately 1.8 million community dwelling older people, meaning not in long-term care facilities, report some problem with basic activities because of visual impairment. About a third of patients over the age of 65 have never used low vision aids that were prescribed from them other than glasses. When you're talking about low or impaired vision, the peak of the prevalence peaks at about age 80, okay? So what are some of those causes? What we're going to talk about, age-related macular degeneration, diabetic retinopathy, glaucoma, cataracts, and retinal detachments. And one of the things that I'll tell you is that prevalence rates will vary based on racial background, okay? If you look at this chart, when we look at some of the leading causes of visual impairment in Caucasian, Black, or Hispanic populations, the most common cause in our Caucasian population is age-related macular degeneration. That doesn't mean it doesn't occur in other cultures or races, but 54% of visual impairment in your Caucasian population is because of AMD. When you look at your Black or African American population, cataracts and diabetic retinopathy are the top two that we see. Our Hispanic population, we're more likely to see glaucoma as a cause of visual impairment. Just some statistics to show you that there is a difference, and you need to be tuned into the possibility that their visual impairment may be due to one of these causes. Now let's talk about age-related macular degeneration first. And you may hear it referred to as AMD, because age-related macular degeneration is a whole mouthful to get out. It is a degenerative acquired disorder of the retina in a particular area called the macula. There are two types, either dry or wet. And what you see with these patients is they have an area of central vision loss. So that whenever you are talking about their vision loss, you can see the two little boys' faces here. Someone with AMD has the loss of that center of their vision, and they would not be able to see the faces until either they turned their head or the little boys moved. It is the leading cause of legal blindness and impaired vision over the age of 65. The dry type is atrophic, which means that there's atrophy of the retina, of the macula. The wet type is exudative, meaning that the vessels leak and cause edema. It's the most common cause of vision loss in persons over age of 55. When you're looking at those folks, what happens is that they notice that reading and other close vision tasks become more difficult. It is a slowly progressive problem. With wet AMD, they get an area of blurred, darkened, and distorted vision that's fairly rapidly occurring. The risk factors, it is a hereditary process. So if your mom or dad had AMD, the chances are likely that you will as well. Other things that increase the risk are exposure to UV light, dietary intake that's lacking in vitamins and minerals, cigarette smoking, and hypertension. For the treatment of wet AMD, we use laser photocoagulation. And one of the things that is very much in vogue right now is the use of omega-3 fatty acids to reduce the risk for age-related macular degeneration. So again, this is a severe loss of that central vision. You can see that basically everything behind this spot where the loss occurred on that macular area of the retina, or that atrophy occurs, they're not able to see without turning their head. As I said, age greater than age 55, smoking, it is slightly hereditary. It's more common in Caucasians. It's common in people with high intake of fats and elevated serum cholesterol. Patients with hypertension and cardiovascular disease and obesity are more likely to develop it, as well as those patients that have ultraviolet light exposure. Sometimes it's commonly seen in people after cataract surgery. And that's probably because the vision is cleared after the correction of the cataracts, and they now can see that loss of central vision. Chronic kidney disease can have a link. And one of the things that we see is that seniors that are cognitively impaired are up to twice as likely to have that age-related macular degeneration. But one of the things they're wondering, is it the cognitively impairedness that makes them more susceptible to having age-related macular degeneration? Or is it the age-related macular degeneration that makes them more susceptible to being cognitively impaired because of the decreased sensory input? Now, the dry type, what you see is there's a gradual breakdown of the RPG, the retinal pigment epithelium. And they have an accumulation of something called drusen. And those drusen basically collect and develop over the photoreceptors on that macula. As I said, it's more noticeable during near tasks like reading or sewing. Of the people that have the dry AMD type, about up to 21% progress to 2200 vision level or worse. And remember that 2200 is considered legally blind. It is an autosomal dominant disease that's affected by nutrition and the environment. It typically affects both eyes, but sometimes the vision can be lost in one eye while the other side may seem unaffected for a while. Drusen are yellow deposits that occur under the retina. This dry type can turn into the wet form of AMD. Because what happens is that because of that atrophy, they start growing new blood vessels at the back of their eye in order to supply blood to that macular area. Whenever you have the development of the wet type, usually is an abrupt onset with visual distortions, impaired color vision, and that blurred spot. Here is a normal retina, okay? Here you can see those yellow drusen, okay? And what's happened is that all the areas that drusen has occurred, you have those photoreceptors that are not getting light. And so that's why that dark spot forms. Now there's several stages, but what you need to remember about this is that early on, they may already have the dry AMD, but there are no symptoms of vision loss. But as it progresses, that blurred spot in that central vision gets larger. When you're talking about the wet type, it's characterized by development of new, weak blood vessels. And what happens is it leaks blood and you get a edema behind that retina pigment epithelium. So it separates or detaches the retina. With that wet type, there's a more profound and rapid decrease in central vision. It causes distorted vision, scotoma, and blurred vision. Okay, what are scotomas? Any idea?
Are they blind spots?
They can be, but they can also, sometimes you may hear them referred to as floaters. Okay, but scotomas are those blind spots. And you may see with this type, you may see floaters as well. Now, the way we check for this is a visual acuity test. That's our old Snelling chart, our friend with the big E, okay? Typically, they do dilated eye exams to look at the back of the retina. Now, those are sort of going out of favor as most ophthalmologists and optometrists have started using retinal photography. Have any of you had that done?
Is that where they put the drops in your eyes and it gets blurry?
That's the dilated eye exam, where they basically, you get everything blurry. Okay. The retinal photography is great in that you don't have to have the eye dilated. You put your eye up against this thing and you have to sort of move your eye in a certain way, and then it flashes and it
Yeah, I've
takes,
had that done before.
yeah, it takes a picture of the back of your eye.
And then they show, and it kind of looks like the pictures that you had before.
Right.
All the blood vessels and everything. Yes.
Right.
I've had that done.
Because it can look, the retinal photography looks for AMD. It also looks for, you know, the thing is that a lot of our patients that have hypertension will have those retinal edema from those blood vessels. And so you can tell a lot from that picture. I would, even though it costs, I think my doctor charges like $30 more.
Yeah, mine was like $15. It wasn't covered under insurance.
It's not covered under insurance, but boy, I would much rather have that than do the dilated eye exam.
Yeah.
Because, you know, if you're by yourself, you got to sort of sit there and your vision is blurry, and driving home is one of those things that, you know, you're sort of taking your life into your own hands if you do that. But I would much rather have the retinal photography, because if you think about it, if they're doing these on a yearly or every 2-year basis, they can look back and see what it looked like the last time and then do comparison. Because if you think about it, how many people have these doctors looked at the back of their eyes with a dilated eye exam? It's sort of hard to remember, you know, 2 years ago, I saw this eye and I might make a few notes, but that picture is, like they say, is worth 1,000 words. So
When I was in practice back, I was an optometrist for years before I went to nursing school, and we would always do retinal photography on all our diabetic patients.
Yes.
On all our ARMD patients. The only downfall is that we would also do a dilated exam yearly, and then the pictures every 6 months, because with the retinal photography, you can't get out to the ora serrata.
Right.
You know, for your retinal detachment patients, but that is a huge tool for these older people who come in because, you know, for driving, you
They
know,
can't
and their
see
medication
anyway.
and the dilating drops interactions with their medications. So
Right.
retinal photography is great.
It is wonderful. With the other part that they will do with this is tonometry. And tonometry basically, guys, is the pressure test. Because one of the things they want to rule out is glaucoma. And so they will check pressures. Now, Amsler grids are something that every patient with AMD should use on a daily basis. It's used as a screening tool. And what happens is that if they're experiencing a distortion of those lines or those central scotomas, they should contact their optometrist or ophthalmologist immediately and be evaluated. And they should test every day, both eyes independently, cover up one eye and then look at it with the right eye, cover up the right eye and look at it with the left eye. This is what the Amsler grid looks like. It's a grid with straight lines. And your patients that have these distortions, like it shows on the right, those are the ones that need to be evaluated immediately. What I usually tell my patients, stick it on the refrigerator, because that's usually somewhere you're going to go every day. And you need to consistently do this on a daily basis with both eyes independently. Because remember, one of the things that can happen is that AMD can progress at different rates for each eye. And so that's why we want to have them check both eyes independently, covering up one versus the other. Now, treatment of dry, there's no treatment that can restore vision. And as a general rule, guys, this is what I'm going to tell you. Once that vision is lost with pretty much all of these conditions that I'm going to go over, nothing can restore that vision. What's lost is lost. And it probably will not be regained. With these folks, we evaluate every 6 months. Just like she said, with that retinal photography, dilated eye exam, just to keep an eye so that it does not progress from that dry to that wet. Because if it does that, they're more likely to lose total vision. Now, AREDS, age-related eye disease study, okay, was a study that they looked to see, is there a combination of vitamins and minerals that can delay the onset of advanced AMD? And what they found is that, yes, there are some supplements that can delay progression. And if you look at Ocuvite Extra or Preservision, okay, one of the things that you'll see is that it has levels of vitamin A, C, E, selenium, copper, lutein, and all those other eye vitamins, okay? What they recommend is that patients that have AMD in either a mild or moderate level take these vitamins and minerals to help slow the progression of that AMD. Now, you think, Ms. Hyde told me that it's hereditary or genetic. So if my mom has this, can I go ahead and take these vitamins and prevent it? Well, that's not what they found, okay? They basically have found that it will help slow progression from that mild to moderate and then from moderate to severe, but it does not stop the fact that you may develop it, okay? And in fact, they don't recommend people that don't have AMD take these because of the higher level of vitamin A. Remember, vitamin A is one that you can become toxic on, okay? The other thing is these things are expensive as all get out. Ocuvite is probably triple the cost of a regular multivitamin. And so it is expensive to take these pills. Now, one of my favorite cartoons is Pickles. I don't know if any of you read it or not, but Earl, who is the guy, says, "What are you putting on my cereal?" And Dot says, "Flax, it's good for you. It's got omega-3 and fiber." And Earl says, "Is this something you got from Oprah?" Okay. And of course, when Oprah was on, or Dr. Phil was on, or Dr. Oz was on, there was a lot of medical information that the general public was getting. But omega-3 is one of the good things that we can do for our patients with AMD. Now, as I said, there's no treatment for dry, but once it moves into this wet, or if they develop wet to begin with, there are 3 treatments: laser photocoagulation, They may also do photodynamic therapy with verteporfin or angiogenesis inhibitor injections are 3 treatments that they can use. Laser photocoagulation, what it does is it basically uses a laser to form scar tissue that seals the blood vessels at the back of the eye that keep them from leaking under that macula. Again, it's not going to restore vision, but it can slow down or further delay damage. They do have to follow up exams to make sure that those vessels haven't started leaking again. Only a very small percentage can be treated with this type of surgery. It's best if those vessels have developed away from the fovea, which is the central part of that macula. We do have a risk of new blood vessels developing after that treatment, and they will have to undergo that treatment again. Sometimes vision loss may progress despite repeated treatments with laser photocoagulation. It's one of the treatments that they use. Now, this one is pretty cool. Photodynamic therapy, it utilizes a drug called verteporfin, or Visudyne is the trade name for it. This is a med that's directly injected into the bloodstream, usually through peripheral IV, and it's absorbed by abnormal blood vessels in the back of the eye. What they do is they shoot a low energy laser into that affected area of the eye for exactly 83 seconds. And what it does is it activates the drug and it destroys those abnormal blood vessels by coagulating them. Now, the thing you have to worry about with these patients is that, it's like aspirin. How does aspirin know that you have a headache? Well, it doesn't. It has that same effect all over the body. These patients that have had this drug need to avoid direct sunlight or bright indoor light for 5 days following therapy with Visudyne, or else it will cause coagulation of vessels in areas that they don't want it to be coagulated. So typically, we don't use the very bright light in the clinic. You have them to, wear sunglasses and hats and long sleeves for 5 days following therapy if they have to go outside. So it's better if they stay indoors, but you don't want them to expose their skin because this Visudyne will cause that reaction in the presence of that bright light. Let's see. One of the nice things about this is this drug does not destroy healthy tissue. This is relatively painless, takes about 20 minutes. And typically they're treated about every 3 months until that neovascular membrane is shut down. It is often temporary, and sometimes the patients wonder if the cost to the patient and to Medicare is worth it. I mean, 4 to 6 treatments at more than $1,500 each. But it's really sort of cool if you think about it. Now, the last treatment are angiogenesis inhibitor injections. And this one was the one I had the most trouble with assisting, because what we're doing is directly injecting this medication into the eye, okay? Lucentis or ranibizumab injections, basically what it does is it inhibited that new blood vessel formation. And so therefore they did not develop to leak. It's been shown to stop and in many cases reverse some vision loss in people with advanced AMD. However, it cost about $2,000 per treatment. Medicare covers the injections, but there's still about a 20% copay. So it's one of those things that it's about $200 for the patient for these Lucentis injections. Now, Avastin has also been shown to be very effective, and it's a far cheaper alternative. Avastin is a monoclonal antibody that they use. It's approved for GI cancers, okay? But before Lucentis was developed, this was what was used for to try to prevent the growth of those vessels. Now, it cost about $200 total instead of $2,000. However, it's not FDA approved for treatment of AMD. And you're wondering, well, why not? Well, the reason is the company that developed Lucentis also has the patent for Avastin. And so if they approve the Avastin, which is a far cheaper drug, no one would want to use the Lucentis. But eventually both of these meds will be off of patent, and generic medications will be more readily available, and hopefully the cost will come down. With these angiogenesis inhibitor injections, they often will need multiple injections and sometimes can be as often as monthly to prevent the development of those vessels. All right, I tell you what I'm going to do. I'm going to stop at diabetic neuropathy because it's about 10 minutes till, and we will finish the rest of this on Wednesday. Basically, what I would tell you guys is take a look at your content. I did post a cataract surgery. Like I said, if you're queasy about eye things, don't watch it. But it is a good representation of how long it actually takes to do cataract surgery. That entire video is about 7 minutes, and that's about how long it takes to do a surgeon to do cataract surgery. I mean, I used to work with some Surg Tech students, and we did clinical at an eye surgery center. And one doc did like 20 cataracts a day. It was amazing. It was like, all right, get them ready, get them in, get them out, get them gone. And it was, they had 3 docs going, doing 20 surgeries a day. It's absolutely amazing. But look at your test blueprint and see what kind of questions you got for me. All right, I will see you Wednesday at 1 then. I'll send you another invite.
Thank you.
Thank you.